Hello, everyone. My name is Dr. K.G. Ishwar, third year resident of radio diagnosis in Lakshmana Institute of Medical Sciences, Pondicherry. The co-authors are Dr. Manipalan and Dr. Nitish Kumar Yaslava. Title of this paper is Diagnostic Imaging of Skull-Based Osteomyelitis, a case series. This case series explores diagnostic challenges and imaging characteristics associated with the skull-based osteomyelitis through detailed analysis of case studies. The aim of this paper is to provide insights into the radiological findings that contribute to its diagnosis, to highlight the importance of recognizing risk factors, typical clinical presentations, and imaging findings by examining three cases from our institution. The patients with skull-based osteomyelitis show non-specific symptoms such as headache, otalgia, facial pain, otorrhea, connective hearing loss, and in case of sinus disease, nasal congestion, rhinorrhea, headache, and fever can also occur. The risk factors include older age, diabetes mellitus, immunosuppression. Diabetic patients can have a cerumen with a higher pH that helps in fostering bacterial growth. A skull-based osteomyelitis is classified based on its origin as autogenic and non-autogenic. Autogenic skull-based osteomyelitis frequently occurs in patients with diabetes and recurrent otitis externa. The other causes include suppurative otitis media or MAPTheritis. The differential diagnosis for an SBO are mainly neoplasms, as they can extend through the skull base to adjacent soft tissues such as metastatic disease, nasopharyngeal carcinoma, sinonasal carcinoma, and lymphoma. Materials and methods. Our radiology department performed all these scans on a somatome scope 16 slice CT machine. MRI used was 1.5 test Siemens magnetomesensor. MRI brain with MRA and MRB was the investigation of choice for the last two cases with CT correlation, whereas the first case had additional investigations done, including a contrast MRI of brain and contrast CT of orbits and pains. Sequences for MRI include spin echo and fast spin echo, T1, T2 weighting, flare, susceptibility weighted, and diffusion weighted images with an ADC map and a 3D time of flight MRI. The CCT technique included sagittal, coronal, and axial sections of the regions of interest. Coming to the cases, case one is a 53-year-old male who presented with the nasal discharge. He had a positive history of COVID-19. A plain CT and MRI were performed, followed by a contrast CT and contrast MRI imaging, which revealed the following findings. So, the MRI images show a well-defined extraaxial lesion, which is isointense on T1, mildly hyperintense on T2 and flat, arising from the region of left cavernous sinus, causing mass effect on the right temporal lobe to clear the area of CSF signal intensity between the lesion and the temporal lobe. The lesion is seen extending caudally into the sphenoid sinuses, posterior ethmoidal sinus, and in the bilateral maxillaris. On SW images, we can see central area of blooming, indicating the process of calcification. On coronal images, we can see that the lesion is occupying the left cavernous sinus, encasing the left internal carotid artery without causing any luminal narrow. The CSF signal intensity is seen clearly on these space images, indicating the extraaxial location of the lesion. On plain CT images, we can see that the lesion is isodense to the brain parenchyma with an area of calcification within it. And the lesion showed intense, smooth, homogeneous enhancement on contrast images. On the bone windows, we can see the presence of extensive bony erosion with altered definition and bone within bone formation and by a posterior aspect of bilateral maxillary sinuses. And also, we can see a few air pockets within the greater wing and lesser wing of sphenoid. And there was also involvement of the floor of right orbital sinus, suggesting the formation of sequestrum. Case 2 was a 65-year-old male who presented with difficulty in swallowing and speaking. Plain CT and MRI imaging of the brain show the following findings. So on MRI images, we can see an ill-defined heterogeneous T2 and flare hyperintense lesion in the posterior aspect of nasopharynx and extending posterolaterally to involve the lateral aspects of bilateral petrous part of temporal bones. And we can also see altered bone marrow signal intensity within the petrous part of temporal bone on T1 weighted images. On CT imaging, we can see a focus of calcification, so multiple foci of calcifications within the lesion. And we can also see extensive erosion that is involving the bilateral petrous parts of temporal bone and also involving the anterior aspect of the clivus. Case 3 was a 42-year-old female who presented with right-sided facial pain and slurring of stool. Plain CT scan and contrast MRI was performed. So, contrast enhanced MRI images show a ring enhancing lesion within the right temporal lobe. And we can also see heterogeneous areas of T2 bar flare hyperintensities within the temporal lobe, indicating vasogenic edema. There was also a smooth pachymeningeal and leptomeningeal enhancement that was seen along in the region of temporal lobe, indicating the presence of meningoencephalitis. And on the coronal T2 weighted images, we can see heterogeneous signal density within the right mastoid hair cells, indicating the extension of infection from the mastoids to the brain parenchyma. On CT images, we can see minimal erosions of the clivus and the bilateral tetrus and squamous parts of temporal bone. The above features were consistent with the right mastoiditis, right petrositis, clival osteomyelitis, right squamous temporal osteomyelitis, and acute meningoencephalitis. In our case series, each patient exhibited a unique symptom that deviated from a classical presentation of a skull-base osteomyelitis, which typically includes deep-seated pain, fever, and neurological deficits. This atypical presentation aligns with findings from Oenger et al., who noted that many patients with SBO may lack typical signs associated with otogenic infection, complicating diagnosis and management. Our second case presented with dysphagia and speech difficulty, where MRI revealed significant erosion in the temporal bone. Schreiber et al. Emphasized that cranial nerve palsies can occur without classical signs, highlighting the need for a high index of suspicion. The third case presented with facial pain and slurring of speech, where imaging showed leptomeningeal thickening and bony erosion. This finding supports reports that indicating that atypical presentations of SBO can include various neurological symptoms without overt signs of infection. CT provided critical information regarding the bony erosions. However, as highlighted by multiple studies, including one by Weitzman et al., CT may not adequately represent disease activity over time compared to MRI, particularly in chronic cases where a bone remodeling occurs slowly. The MRI was instrumental in identifying soft tissue changes and subtle bone marrow alterations. Studies have shown that MRI is superior to CT for monitoring disease progression due to its ability to detect early changes in soft tissue involvement and bone marrow area. Oenger et al. Reported that CT alone failed to detect the disease activity in 80% of the cases after initial scans, underscoring the limitations of CT in assessing a skull-base osteomyelitis. The differential diagnosis can include a squamous cell carcinoma and nasopharyngeal carcinoma, which can also involve the skull base. In conclusion, skull-base osteomyelitis remains a challenging condition requiring a multifaceted diagnostic approach involving clinical evaluation, imaging studies, and microbiological investigations. Integrating advanced imaging techniques such as CT and MRI can significantly aid in differentiating a skull-base osteomyelitis from other entities like nasopharyngeal carcinoma. Ultimately, a collaborative approach among radiologists, clinicians, and microbiologists will be essential in tackling the complexities associated with the skull-base osteomyelitis. These are my references. Thank you.